Hello, everyone. My name is Deborah Kahn. I am the founder of Being Patient. Today, we are kicking off our panel on achieving health equity in dementia care. And one of the things I love so much about my job is I meet really inspiring people to talk to. You're looking at them on the screen right now. The reason why this topic came up is because Being Patient launched a series on diversity and dementia, and I got to hear a lot of people's stories, problems and solutions. And I thought, how powerful would it be to have these people on one panel so we can really understand some of the problems in the system and some of the solutions. And I should say that this panel was generously done in collaboration with Eisai Inc., a human healthcare company. So we are grateful to Eisai for helping us raise this issue. So welcome to my guests. I am going to introduce you all. Just wave when I introduce you. Arthena Caston is no stranger to Being Patient. She's been on several times. She has been diagnosed with early onset Alzheimer's and is a major advocate and recently appointed to the Dementia Council. Is it Athena for the G8?
Yes, the World Dementia Council.
Which is amazing. Congratulations to you. Next to Arthena is Dr. Fayron Epps. Fayron has also been on Being Patient. She was in healthcare in nursing and later got her PhD and has articulated and formulated toolkits and programs for Black churches to increase awareness around dementia care. Welcome, Fayron. It's good to see you again. And David Williams, who is a friend, and so impressed with what David's doing. He is a tech entrepreneur and has spent a long time in healthcare and has a platform which helps people keep track of everything to do with their health called Care3. So welcome, David.
Hello.
Okay, so let's kick off. I want to start first let's start with the problem so that we can really talk more about solutions. Arthena, I want to talk to you because you and I have talked about this before. As a Black woman who was experiencing memory issues in your early 50s, how hard was it for you to get diagnosed?
It was very hard. It was really hard. The problem was because I was so young, my doctor kept thinking, I laugh about it now, that I was just in menopause. And I went through menopause for I don't know how long. And I just kept saying, this can't be real. And he just kept saying, and I know the whole reason why now is because I was so young. He just could not believe or did not want to believe that I was actually experiencing early onset. And so that was a challenge within itself. And we went from that, because I think my husband said now he thinks I probably started in my late 40s and going on. So I actually did not get the diagnosis until I was 51. And I had gone from so many doctors at that point, and they all kept saying the same thing. I think you're just in menopause. I think you're in depression. You know, it was everything except what the problem was. And so I was just lucky one day to hear someone talking about another doctor. I got referred to that doctor, and then he answered all the questions that I needed to know.
So I remember you told me that, you felt in some of those conversations, like it was difficult to get the doctors to take you seriously as a Black woman. And sometimes the conversation was even directed at your husband. I remember you saying that. Can you tell us a little bit about that experience? Like, why was it always like, oh, it's just menopause, and not, why do you believe, it wasn't really like, this is Arthena and I know myself and I'm having problems? Why was that so hard for doctors to believe?
I think number one, because the first thing they wanted to diagnose it as everything else except that. You had every reason to tell me I had a problem. And I constantly think back now to when I speak to my other friends, and I hate to say that, who are of other races, especially the Caucasian race, the first time they went into the doctor and told them, I have this problem, it was automatically, well, let's do some testing on this. Let's do some testing on that. Let's do some testing. I went to my doctor for almost 2 years and he never asked me for any testing, never thought about anything to ask me for any testing. And even when I would say, or we would, bring it back to talking about my husband, it was like, well, are you stressed? It was always about a stress issue. It was everything except I'm always looking for the negative. But then it came down to me and I started saying to my husband, we have good insurance. Why am I not getting tested? Why am I not getting treated the same way as some of my cohorts? And it got to be real frustrating after that, because it's when you're dealing with the same doctors. And then it got to the point where it's like, well, I went to one doctor, and I remember he said, well, you need to see this doctor, but he doesn't take Medicare. And I thought, I don't have Medicare. So why would that even be a point here in this situation? It always seemed like it rolled back to, did I have the money? Yeah. That's just the way it was, do you have the money to take care of these things that you need? You do know MRIs are very expensive. That's fine. My insurance would pay for me to get an MRI. That's frustrating now. And it's even more frustrating now when I talk to people who I know are like me, who are my same color, and they're going through that same issue right now. It's not about anything else except, do you have the money to pay for the testing? That's it.
So David, one of the things that you and I have talked about in the past is like the conscious and unconscious bias that's packed into the system. And that's, reasons behind why it is harder for African Americans to get diagnosed. Tell us a little bit about the conscious and unconscious bias that's packed in there, and maybe some examples that you've seen.
Absolutely. I think what we have to recognize is that anytime we interact with the healthcare system, we're talking to people who are extremely smart and study data, cohorts, populations, and how they behave. And that information can benefit us individually as patients. But at the same time, if those populations are still not constructed in such a way that represents what the general population is, or someone who is more like you in Arthena's case, we're talking about the ability to introduce systemic, unconscious, and unconscious, which Arthena also gets to, the conscious bias of it, because of those data sets. So for example, if you look at the participation of African Americans in clinical trials, okay, and I bet you Fayron knows way more about this than I do, but one of the things that I've always noticed is that there's always a small number, especially in the largest disease area in the United States, which is cardiovascular disease. About 2.5%, according to the FDA, of the populations who participate in those trials are African American. But when you think about who has a more prevalence in their population of having cardiovascular disease, it's African American. So what happens? You have a mismatch in the population that's being tested in trials and the people who are getting treatments. And one size does not fit all. So what happens is that introduces unconscious bias when somebody is trying to introduce a treatment for you, because the population may not actually be reflective of your experience. So that's just one example.
Okay, we're going to come back, but I saw Fayron enthusiastically nodding as you were talking about this. Do you want to add to that, Fayron?
No, I just totally agree. I just had a conversation this morning about how can we get more people enrolled, but also not putting it on the burden of the people, of the communities of color, but also the researchers and the scientists on the other end, making sure they introduce these opportunities and educate the communities that we really need to have participation in these clinical trials. So when we have treatments and programs and interventions, that we know that it will also work for them as well. And we're not just, my thing is, if you're not participating in the trial, you informally, you're participating in the trial, because you're going to be receiving some treatment that was never tried on your population or your group. And so, however it goes, if we look at it like that, we should want to participate And so we can help change the mindset of healthcare providers so they can see a different narrative. And so then they will be better informed on how to interact with all persons.
So how do you change that mindset? I mean, that's really at the crux of the matter, right? How do you change a mindset? It's not an easy thing to do.
It's not. And I'm not sure if the question was for me, Deborah. But
no, please, I'd love to hear from all of you. Yeah.
But, you know, that's really, I think a lot of us know that this problem exists, right? And that is the big question. How do we change the mindset? And I will tell you personally, what I've done and my team has done is we've taken a different approach. And now we feel that, okay, it's hard for us to change the health system. That's how are we going to reach all of these physicians or providers, I should say. But let me reach the caregivers and let me empower the caregivers with the right tools, the right knowledge that they need. So when they interact like Arthena did, and they can say, wait, I have this insurance and this is what my insurance covers. They can also demand, you know, again, a power, they can speak up. And so that's part of the thing I have going called Caregiving While Black, but it's my answer, my team's answer to how we can change the system. And it's us empowering the Black patients, Black caregivers to interact with the health system with some knowledge and demand. And I did say demand is kind of harsh, but I mean it. So they can demand the care that they deserve and need.
Yeah, and absolutely. And one of the things, for those of you who don't know what Fayron is doing, she has really articulated dementia care programs and actual toolkits, and is really distributing them and educating Black churches in order to kind of take some of the taboos out of people living with dementia and really aiding people in terms of understanding, am I getting this right, diagnosis and care throughout the journey. Is that correct to say, Fayron? So David, tell us a little bit about changing the mindset as well, because I know, you know, you're passionate about giving people the tools vis-a-vis data. So tell us a little bit about how, you know, I mean, Arthena obviously is very educated on the disease now, but when she was first entering, was there a way to give her a different experience? Like, should she have known something that she didn't know at that time?
Yeah, that's a great question. I have a very clear philosophy about how data works for us as individuals as well as for populations. But when you think about, you know, historically in general, how do you overcome bias of any kind? It's through data. It's through information. It's the ability to say, how can I influence the person who is making a decision about me? And how can I do it in such a way that is focused on me? What Care3 does is it gives you a platform to capture your personal experience, and we structure it into data. So what we want to do is to say, when that doctor or when that provider is making a decision about your treatment or your course that will happen in your action plan, the biggest influencer will be you, because they will have a clear picture of what's happened to you, maybe since your last visit or over time if it's your first visit, because that way, they know the decisions that they're making are going to be personalized. The first way to get ahead of the bias is to make sure that every decision is being made on your experience. Then they can use that, their big brains and all of the information that they have at their disposal to be informative about those decisions. But if you don't go to the doctor or don't have a telehealth session armed with your own data, your own experiences, then you've essentially said to that provider, well, go in all these other directions and in your judgment, do what's best for me. And here's how we can win, because they all want to personalize our care.
Okay, well, let's unpack that a little bit, because I think that's really important. I mean, it's astonishing that Arthena it was 2 years. She was seeing doctors for 2 years and no one was taking her serious that she was experiencing memory problems. So what does that look like? I mean, what could she have brought to the appointment to say, listen to me? I mean, I can't believe I mean, Arthena, I can't believe it took 2 years. That's like huge. That's a long time in this disease. 2 years is a long time. And we hear, and she's not the only one. We hear this over and over again. Like women who are younger, who are experiencing memory problems, they're always told it's menopause, but it's not menopause.
Well, actually, I would ask Fayron, I would ask you, Arthena, first, like, how did you get over the hump finally? What did you tell your care team that they finally said, you know what, we need to test? What happened there? And then I can come back and say, this is maybe how we can help other people avoid that same journey that you had to take.
I wouldn't want to say that in public. No, but I'm just kidding.
I have to go on mute for that.
I'm sorry. What happened? My father had David. My father had Alzheimer's, and 6 of his brothers and sisters had it also. So I knew what it was. I knew when I started, I knew what my symptoms were. The only thing that was different between me and my father was because he was in his 70s and I was almost in my my early 50s. That was the only difference. So when it got to the point where it's just like I'm constantly going, I was getting frustrated at that point because I was still working. I had a hard job it was just really, everything was just not working out. And I finally just said, listen, this is not working out. This is not working out. You can't keep telling me. I had gotten to the point where I was going to the doctor like every week. And my husband every 2 weeks. And my husband kept saying, you're going to the doctor every 2 weeks. You coming on with a different pill every 2 weeks, but you're not changing. Everything is still the same. And at that point, I just said, listen, this isn't working. This is not working. I either need to find a new doctor or this is just not, and I had this doctor for like 18 years. I need to find a new doctor. At that point, he went on to send me over to a neurologist who sent me on to a neuropsychiatrist. And that's when things finally started rolling. But I had gone to him and I was teasing him now because he's still my doctor. He just kept saying, you can't be, this can't be, you cannot have a memory issue. He was so caught up in this menopause thing that that's all he saw was menopause. That's it. And the menopause thing, and we laugh about it now. And I finally said, how long am I supposed to be in menopause? Because I've been in menopause a long time, but I wasn't having the hot spells or anything like that. And I kept saying, how long am I supposed to be in menopause? And he finally just said, let me try something else.
I mean, but this notion that women just completely can't remember anything during menopause is, I think, being played up a little bit too much. It's not like all of a sudden you go into kind of what's mimicking neurodegeneration. I mean, it's just like a little bit crazy to make that presumption. But what's astounding to me too, David, is this is a woman who has a history of Alzheimer's in her family over and over again. And she's saying, I'm having cognition problems, and no one's believing her.
Right. I mean, we can get into that. That is conscious bias. That is not unconscious. It's conscious. And Arthena, you said so, like, it can't be, so let me not even go there. That is actually a conscious decision, right? But you did this, the thing that you did was you brought your family history to it. That's data, right then and there. And then the next thing you did was you actually advocated for yourself by saying, I need to find another doctor, because believe me, that got the attention of your doctor because something wasn't right. You kept saying over and over and giving proof in the way that you were, disturbing, saying, this is a problem in my work. This is a problem at home. My husband is recognizing this as well. It's not working. And I think it's that self-advocacy that we as people also find very difficult when we're interacting with the healthcare system. And so what I advocate for is for people to use their own experiences like you did and put it into structured data, because that's what doctors hear. That's what they see. If you could say, look, over the last week, I've had 4 times my husband said that I had a memory issue. And it was on Monday, Tuesday, Wednesday, and Friday, right? And this was the issue each time because we wrote it down. Then that becomes indisputable evidence.
It does. I have a friend, and she says all the time, and Fayron knows her, my friend Terry, she always says, you have to be your own self-advocate. You have to be. There's no if, ands, and buts about it. But I recently read an article no longer than I think it was 2 or 3 days ago. And the first thing they said was it was about Alzheimer's. And they said, if you're a woman and you're having memory problems, it's probably menopause. This was not even 3 days. No, it's not. That is not the case. That's not, but it was an article in a magazine and they were really serious about that. I thought,
Maybe we need to go to more doctors who are over like postmenopausal. Like maybe that's more women doctors.
Even if it were menopause, the whole idea of self-advocacy is not not restricted to any diagnosis. I mean, as an activity. So I think you're hitting the point there, which everybody should know. You should be your best advocate. But I think that your ability to capture your experience in such a way that convinces a doctor to take the next step is your self-advocacy. I just advocate for people using it with data. That's really, I think, where I stand. My line is the best way to get a doctor's attention or a nurse or a therapist is by giving them data, because 2 things. One, they'll be shocked that you have it in that kind of format, first and foremost. But secondly, that's just how they're comfortable dealing with problems. If you give them data, they're outstanding, but they need that from us as individuals.
You're speaking their language.
So how do we, so I guess my thing is, David, is, that's great, but how do we get Black caregivers, Black individuals to understand that concept? How do we get them to know that they can bring this to the doctor? Like they have a voice. I mean, I think with my background as a nurse and just interacting in the healthcare field, in the healthcare community, there's so many people that feel like, oh, all right, they have a white coat on, they're right. And I'm gonna listen to them. And even in my own family, well, whatever the doctor says, but they don't want to bring that data. They don't want to speak up neither. And I think that's where we find a lot of, I guess, I'm not gonna say inequities, but like we just listen. I don't know if you get what I'm saying. It's hard for me to it's just like, I'm from down south. Right. my what you said, Arthena?
The doctor's always right. That doctor is right.
Yeah. And I'm from down south and my family's from the rural part of Louisiana. And I'm telling you, whatever that white coat says, that's what it is. And to me, we almost got to fix that. We have to empower our people so they'll know that, no, that's not the case. In fact, they probably only took one class. That's probably 30 minutes on dementia or whatever that, specific condition you have. And so it's really up to us to incorporate data, to incorporate other things, and to bring that to the table so we can get equal treatment and really have that opportunity to continue to thrive.
I think your work hits right at that cultural issue, going to the churches where there's another voice of authority that people respect, the pastors, the entire set of clergy, the folks that are there. That's what makes that such a powerful venue through which to communicate in terms of getting cultural messages across. I find that I've actually pursued trying to talk to the churches about data, because data is a far concept to people. They're just like, what do you mean data? And I'm saying, no, it's your experiences, really. It's just essentially given in a way that it's structured in a way that a doctor is going to understand what you're saying. And it doesn't come off as ranting, because that's really what we're also trying to do. In one of the other webinars, actually, I think, Deborah, you attended this one. I talked about that white coat. I was like, the problem is, in some cases, it's also like a white hood. And we have to make sure that's not the case, too.
Wow.
Because we have to make sure.
Pause, David, pause. I just need you to pause 1 second.
You're gonna write that down.
Wow. I think the audience needs to let that sink in, baby. Like, wow.
The idea of bias
So let's talk about that. Let's unpack that there, because I think that's also, we've all, the three of us have all talked about, the four of us in different ways, talked about the historical challenges, especially within the Black population and science. So let's talk a little bit about that, because there's a history of mistrust that is already being passed down through generations. How is it possible to make a new start? Or like what you just said, David, which is so powerful, like the white coat representing something that is very white and not, speaking the same language, and which has symbolisms of past history. How do you even start to deal with that? That's a very long historical mistrust of people and the system. So where do we address that? How do we address that? And I'm putting it out to all three of you.
As the
if I had all the answers, but I think the way that I've always approached it is, one, you obviously get the benefit of the doubt first. I mean, but the best way to self-advocate, which we all would agree that should be the behavior that we adopt, that self-advocacy. However you do it, you have to do it, and it will end up working in your favor. Whether it becomes, I need to still switch doctors because you're not listening to me, you're not taking my experience into consideration, or the doctor does. And you end up getting on a path where you can have that discovery. You can have the diagnosis occur as it's supposed to, and in a timely fashion, so that you can still live your highest quality of life given that situation. The self-advocacy, I think, is the behavior. If we can get people to say, I can speak up for myself, Fayron, to your point, I can, and here's a way to do it, that arms them with that kind of interaction and confidence when they're talking to that doctor who's in a position of authority.
So go ahead, Fayron.
Now, I was going to flip it, that's us speaking to the patients, but, for those that are tuning in that are wearing that white coat, right? And want to do better, because they have some that want to do better and they want to make the change. I always tell practitioners and clinicians, or those that are serving a diverse population, acknowledge, don't just go in the community or go in and just know that, oh, well, that's a long time ago and it should be different now because it's 2021. It's not different right now. And so I think you need to acknowledge that did occur. And if your patient brings it up, it's okay to talk about that. And the problem is, just like a lot of practitioners don't like talking about religion and spirituality, but these are things okay, because if it's important for that patient, then it's important to their plan of care. And I think they need to be able to talk about that. And then also listen how this history has impacted them. And then they'll know how to treat that patient.
Arthena, I want you to talk to us about, you've participated in clinical trials, I think, am I correct?
I have. Actually, I'm getting ready to be in a new one. They have a new one out that's out. I think it's called Ideas. That's very, very, I'm hoping everybody and their mom and sister and brother can get in that, because it is geared toward us. That we have so many. The problem with clinical trials, and I've talked to many people, and not only for Alzheimer's, it's like, I'm not doing that. I'm not doing that. That's the first thing they say. And then when you start saying, well, why won't you try it? Then you start hearing these all off the wall, crazy, it's just almost like the issue we have now with the getting the shot for the virus. It's always a reason you don't want to try it. But my point is, why not try and think about a reason to get it instead of not getting it? My husband says all the time, he was trying to have this conversation. He said, why not try? Why not try? Because he reflected it back to the virus. He said, don't be in a situation where you don't know, but you're speaking about something you don't know. So, first, for a while, when I started trying to get the trials or get in the trials, I was like, oh no, you can't get it because you have epilepsy and you can't take the medicine with this. And it was going back and forth and back and forth. I was like, okay, that's fine. But as soon as they started offering me a clinical trial that said, Athena, you can get in it. We have new medicines coming out. Because as I said, when I spoke to the FDA, I said, I have nothing to lose. I have nothing to lose. And I encourage us as African Americans, I plead with us, not only African Americans, but anybody, get in the trial. Try the trial. If it's not for you, they'll let you know it's not for you, it's not working. But you learn something. I never understand people who said, now, first, like I said, I was kind of, I don't know, but as I said, I have nothing to lose with the trial. If they offer me every trial there is, I'm gonna take it.
Did you have a fear of science at all before you participated in a trial?
Not really. I've never really had a fear of it. It was so many, the only problems I had with trials is because, as I said, I had been diagnosed with epilepsy. So a lot of the medicines I could not take, or they would say I would have to stop taking my epilepsy medicine to be in a trial. And I was thinking, okay, well, I'm definitely not gonna stop taking my epilepsy medicine. So that was totally out. And that put me out of a lot of trials. But now, I'm coming in and they're saying, oh, that's fine. You can still take it. And then I take it and not have a problem with it. As I said, and I'll say it again, and I'll say it to people all over, you have nothing to lose, especially with a disease as powerful as this one, as condition. This is something that we cannot, there is no cure right now. We need to have as many trials and do as many things that we can to stop this. And with our numbers being so high, and when I say our numbers, I was speaking of, especially on African Americans, we need to get in these trials. Yeah. We speak about that all the time. We need to get in these trials. We really do.
What have you gotten out of the trials that you've participated in? Did you get information about your health and, the state of your brain? Like, what types of feedback did you get?
Well, the first one I took, it took me a while to get in. It gave me, because, for the new drug that just came out, you have to have like a PET scan.
Yeah, Aduhelm you're talking about.
Right. You need to have all these powerful tests. And to be honest, those tests cost a lot of money. Well, the one trial I got in, it paid for all of that. Everything was paid for. So I didn't have to worry about, I can't afford that test because it cost $7,000. And several people who I know who are either preparing for the trial or in the trial have had no problems with it. So again, why say no? Why say no? When later on, I'm always the one that wants to say, I'm going to be the first one that says I'm cured. I may not be, but at least I tried. That's just the way I feel.
And that's an important point. And also, David, one of the things that I kept thinking as Arthena's speaking is, she part of the data is also like, look, I have a history of epilepsy. I've been on this medication. Is that what you mean as well? Like, come prepared with all of these details about your own health, because chances I find, like in the care of my mom, oftentimes those doctors don't read what's in their electronic medical records, right? So you really have to say, look, this is what she's had, or this is what, right? So is that what you mean? It's like, it's not only having to do with Alzheimer's, it has to do with everything. This is a profile of my health, right?
That's right. When you go to the doctor, typically, especially if it's your first time, they want you to fill out a family history, right? They want to have record of what your family history is. What I'm saying is that you can go in with any kind of history. You can have your family history. You can have your last 3 months history, whatever way it can be, articulated to somebody who can help you, try to help them. But it gets them to know you better so that they can customize their treatment and their action plans. And all of those things are important, because the less you trial and error, the better you have a longer quality of life, higher quality of life. That's what you want, less of. So the thing that I find is also difficult about the medical system is that it's silent. You find that everybody has a specialty. And so it's hard to say if I have dementia and epilepsy are lucky you're going to deal with a neurologist most likely in both cases. but you'll have cases where somebody has, cardiovascular disease and they have dementia. And so when you have to deal with both of those practitioners are going to want to know what the other are doing. And they do want to understand your experience across both, because it can impact what medications they'll recommend. It can impact how long or what dose. It can impact the actual your metabolic rate, how well you metabolize certain medications. I'm like, I can't do that. Live shows. So the thing about sharing all this information really is for your own benefit, but it does help doctors, especially when they're not in the same specialty, make better decisions and more personalized decisions, because that's the goal. Otherwise, they might try something and you have an adverse event on the medication, and they don't want that. They don't want that at all.
So, and I love those suggestions, but Fayron, I want to talk about, because you and I have talked about this before, is like the stigma of I have dementia, right? There's big stigma. So like when we were talking about this, you said a lot of people within their own families don't want to even go there, right? So with your experience of what you're doing in the Black churches, how do you take the stigma away from saying I have dementia? I mean, because if you can't even say it, I mean, you're not going to forget the trials. You're not even going to get the treatments, and so how do you break down those barriers within stereotypes?
Yeah. So we can no longer be silent. And I was going to piggyback on what David said, and this leads right into the stigma. As I was developing this Caregiving While Black course, one of the things, and me working in the community, working with families that are facing dementia, I don't want nobody in my business, right? And that's a barrier to so much, a barrier to life planning, a barrier to getting treatment, just a barrier to getting help. Is because, especially we as Black people, we are very private and we don't want no one in our business, even if they're blood related. We don't want them in our business. And I'm just being honest, and others may feel that as well, but I know particularly in my family, I don't want nobody in my business. But we have to break that cycle. And, by us having these conversations, that's why I go out. I'm going out tomorrow. I'm going out Saturday, paving the ground to have speak on dementia awareness, to speak on brain health, to have these conversations. And I know immediately they're not going to be like, yes, I deal with that. But I have to tell you, months down the line, they will come to the church. I had a caregiver call me last week, and I was like, okay, well, where did this come about? And she said, well, my pastor, he has been talking about dementia for a while. And she just been sitting back listening, and she said, but I finally reached out to him and told him I'm a caregiver and I need help. And then that pastor bishop put her in touch with me. To me, that was a win, right? Because she now finally said, you know what, the pastor did great, because I'm not saying he's normalizing it, but he's letting them know this happens. You can talk about it. I'm here for you. She felt that comfort level. And then now she's able to get help. And so it's a slow process. And people say, how many people are you impacting? How many people you're changing their minds? It's not about the number, right? If I feel like I'm changing one person, then I know that person is going to be able to help the next person. Yes. So point blank is, Arthena, let them people in your business, okay?
I don't have no problem. I told the very first time
we don't know how we met, but yeah.
I told her, I said, we've always had that what goes on in my house stays in my house. This is not something that's just starting. This has been something that's been going on since slavery. That's just the way we started. It started in slavery and it kept on going. So I have no problem. Fayron has known me, I don't know how long, that's been well over a year or so. And I've always been a person that's been very talkative. I tell people what's going on. I have no problem with it. And when I speak to people, when I speak to large groups, I always get that reaction at the end. Can I speak to you? Can I talk to you? Can I have your telephone number? Yes, you can. You can have my telephone number. I'm gonna give Fayron number too.
And she does.
We,
I
we
give Fayron.
I'll stop short of publishing your phone number, Arthena. But that's amazing. And what you all are saying is it really does start at the grassroots level, right? It's like,
It does.
and I totally get what you're saying. I'm half Asian, and it's the same in the Asian community. When you have something wrong with the brain, it's not something that's talked about. We keep it in the family, right? And all of a sudden the person doesn't go out anymore, and you keep it in the family. And it does make the journey and the process so much more difficult. I mean, doesn't it feel good to talk to other people, right? Who, I mean, with all of your advocacy, all three of you, I mean, when you realize you're telling people it's not a bad word, it's okay, you know, it does feel good. It is empowering to.
What makes it so sad though, Deborah, you know what makes it so sad is that we have this so much in the brown, and I say the brown, not only African Americans, not only Latin, it's the brown people. Because when I go to places where I have gone, I think I spoke to someone, it was like 900 people, and all the Caucasians had no problem telling me. They was all over. Can we talk? They have no problem. When I go, I have been places where I have been the only African American there speaking and talking. But they have no problem telling the story. But us as African Americans and people of brown, this is what they're doing the whole time. And they may come out after everybody has walked off and say, can I talk to you? They're not going to come up when a lot of people is there. They may slip you their telephone number or something like that, but they do not. It's just like, we have to keep this secret. It's a secret. I don't want nobody to know. You're not going to tell nobody, are you? Yeah, okay, I won't tell nobody. And this is what's going on.
Yeah. So what you think, Arthena? I'm sorry, Deborah.
Go.
So do you think, you know, as you were talking, Arthena, you know, I'm thinking this really has something to do with our history. So it even go beyond what happens in the house stays in the house. It also, do we, in the society that we are in right now, even in my role working at the university and as an assistant professor, I don't want to show a sign of weakness. I don't want to show that somebody can challenge me and maybe I'm not up to par now. And me as a person, I don't want that to happen. And as I'm hearing you speak, I'm able to really sit back, and now, you know, maybe that could be the case. And wow, then yeah.
That's what it is. That's what it is. Because the thing is, Fayron, and I know you know it, the thing is when I'm speaking with my members of the board or whatever, you know what they always say to me? They always say, we really like you, Athena, because you speak out, you talk, you say what's on your mind. And I'm thinking, I do. I always have. Fayron teases me about it all the time, but I always have. I've been that person who speaks out and will say what's on my mind, because you hiding it is not going to change it. And if I can get the people who come to listen when I'm speaking, if I can get them to say, I have a problem, can you help me? Or someone will give them someone else's, give me, you know, my number is transferred all over. And I don't have to know who I'm talking to on the phone. But I love the fact that they are calling, because as Fayron said, if one person will call, then they'll tell somebody else, and somebody else will tell somebody else. And that's where we have to start. Being weak is, in this society this day, is hard. But you know what? I would rather, when I met a mother the other day whose son, I think, was 28, and he had been diagnosed with early onset.
Wow.
That was the most astonishing thing to me. But it's happening younger now. So at some point in time, somebody has to let go of that weakness and say, you know what? It is what it is.
I see you nodding your head, David.
Oh yeah, no, the thing about family caregivers being the people who also need to be let in, but then also have access to those experiences too, because a lot of times what happens is, and this happened with my grandmother as well as my mother prior to her passing, she was showing her signs of dementia. that they can't recall things in the doctor's office. And so having a family member, your adult children usually are those who can also say, or, or a spouse who can also say, hey, look, these are the things that are happening. And, we're recording it because we want to make sure we have some record. Letting those people in so that they can do those things, to have that information can also be really helpful. And it's hard even, I know it was hard for my mother, but it is hard for people who took care of you, changed your diapers, to not only deal with, their own health issues, but then to have to kind of change a role where their child has to step up and, somehow they feel like they're a failure at that point as a parent. And, what I had to tell my mother and even now my father is that that's not the case at all. I mean, you help shape us. We want to help you live the best life you can live. And that's our job now, and that's okay.
It is.
So the ability to let those people in who care for you and have high motivation to collect information, to share that with a care team can also be immensely helpful.
Yeah, so much starts in the family too. And I love like what all of you have said. And I found this conversation incredibly important and uplifting. I wholeheartedly thank all of you. You both, all three of you to me are true inspirations. I was determined to have a panel to talk about solutions as well. We know the problems do exist. It will take time, but it's going to take people like you who are working at the grassroots level to really inspire others to change the whole system of how things work. So I'm grateful. David, Arthena, Fayron, thank you so much for joining us today. It's such an important topic and conversation. So thank you. To those of you, we have another talk coming up where this afternoon in a few hours time at 2 p.m. Pacific time, 5 o'clock Eastern, we are going to interview Ronald Reagan's daughter, Patty Davis. So please join us for that talk as well. As we know, the former president was impacted and died of Alzheimer's disease. But until then, we look forward to more information. Thanks very much to our partner in collaboration, Eisai Inc., a human healthcare company, for this talk as well. So thank you all three to our guests, really inspiring, and we look forward to staying in touch.
Thank you.